Hi, everybody. This is just going to be a catch-up lecture on our second ultrasound topic. My apologies if I'm a bit under the weather, had a tummy bug. Um, so if I look a bit dehydrated, that's because I am a bit dehydrated, but I'll do my best. Since I may not get time to do these at another point. So, what we're going to do today, or what we're going to do in this lecture, is just recap beyond what we learned the last time, which was just knobology and basics physics. And physics of ultrasound is actually quite involved. It can go quite far, and it's more for radiologists at the end of the day, because it helps them to look at a lot of things that we don't necessarily look at in the emergency department, or in an outpatient setting. So let's get on to it. All right. So this was done on the 20th of January. So we're going to discuss what's the purpose of eFast and where we start, which is normally the liver. So it's optimized for video, so I can't see myself on here. So if for any reason I pick my nose accidentally, please forgive me. Simply, no, I'm just kidding, don't worry. So let's start it as a full lecture. So there we go. Ta-da, ultrasound. I want to get one of these fancy computers where I can put beautiful background and lovely sound effects and things like that. And maybe a nice mic that I can attach to the computer. Maybe one day. I'll also be like those dudes that, in India who build all those modes and that. We've got like 100 million viewers where they build stuff with sticks. Maybe you could have Dr. Mohammed on YouTube as well, pointing out all the things to do in ultrasound, and all the other doctors in the world laughing and saying, geez, that's wrong. No. So let's go. So today we're going to start talking about ultrasound in the emergency outpatients department, which is where most of us are working. So what does it stand for, EFAST? Now, it doesn't stand for uh, a fast ultrasound that's done electronically, like an EFT or something like that. It stands for extended, focused assessment via sonography in trauma. All right. So what happened was in 1984, it was decided that ultrasound could be of a lot of use in the determination of a polytrauma patient and how bad they are doing. Because very often our polytrauma patients come in with very low BPs. They come in with signs of injuries that we can't necessarily pick up. And by the time we image them, they've deteriorated. So if you can image them immediately, it gives you a good idea of where you need to go first. So that's the historic background. Okay. So let's just go to that. So this was the initial FAST scan. The FAST scan consisted purely of an abdominal examination that looked around the liver, that looked around the bladder, and that looked around the spleen. And it was first developed to look for fluid around the liver, around the bladder, and around the spleen. It's evolved from then with the eFast, of course, with the eFast also encompassing all of these things. But now we look for liver injuries, we look for bladder injuries, splenic injuries. And sometimes in the spleen, we can look at retroperitoneal injuries. We can look at diaphragmatic disruptions. We can look at kidney disease. There's a lot now that can be done in the emergency department that couldn't be done 40 years ago. Number one, because of the clarity of the picture that we get even on the most basic machines. Um, I can tell you that I worked as a GP for a long time, close on to 10 years. And about 2 years ago, for various reasons, I had to go back to the practice where I used to work. Not to work, but I was just visiting. And I had to use that old machine again. And it was kind of like looking at a picture through heavily stained glass, like what you'd see in a shower door. And I can tell you the advancements are amazing. What we can see on our machines now are 10 million miles ahead of what we could see even 15 or 20 years ago, and it's just going to progress. So that was the initial fast. Then came the extended part. So the extended part included the pulmonary, basically the pleural space. So what happened was the pleural space was being looked at in order to determine is there pneumothorax and is there a hemothorax or a fluid collection. And currently that's the scope of EFAST, okay? And then, of course, later on, we went to the cardiac views. Well, Ziphi-sternal subxiphoid, there's two, and long axis anterior parasternal thoracic view. Now, actually, we're actually going to get to this very soon. And in fact, now in the EFAST, we also include volume determination. In other words, our patient hypovolemic, but it's not technically under EFAST. So when we get to that lecture, you'll understand why, because there are a few pitfalls as far as that goes. Okay, but it gives us a good window, a good opportunity to look at what's happening with our patient. And a good EFAST exam, thorough EFAST exam can be done within 5 minutes and gives you tons of information about the patient, because it allows you to stabilize the patient, to know where the problem may be, start doing interventions that will help to stabilize, determine your fluids. So it's an exceptionally good tool to have. And it's something that I think every doctor, once they reach at least the end of the community service, you should be able to do. And if they haven't been able to do it by that stage, at least as a first year MO or at any stage of their life can learn how to, but ideally you should be learning it in your junior years, okay? So what are the pros of it? It gives us quick bedside imaging, very quick. I mean, it takes nothing. In our department, we just have to wheel the ultrasound from one side to the other, plug it in. It needs a new RAM card because it takes a damn long time to actually boot up. It feels like it's forever, but in reality, it's only about 3 or 4 minutes until it's booted up. So what we're looking for in the EFAST is free fluid in the abdomen. That's essentially what we look for. As you become more advanced and as you get more into ultrasound, you can start looking at acute injuries. So acute injuries of all abdominal structures, the liver, the spleen, pancreas sometimes, vascular injuries, bowel injuries, bladder injuries, uterine injuries, all of that. So you can see all of that. You can start seeing infective processes, for example, TB abdomen. You can start looking for pelvic abscesses, psoas abscesses, things like that. Signs of renal compromise, things like that. OBGYN and fetal assessment, this comes a little bit later. It's not at the forefront of the EFAST, but it comes to the forefront of the EFAST when you are dealing with a pregnant patient, of course. There are a few gynae emergencies that are quite important for us to know and that we should be able to pick up, and we will get to those. Obstetric as well in terms of trauma, as well as fetal assessment. There's a lot that we need to know there, but that will be a whole section of lectures. Vascular assessment, particularly triple A's, but we also look at the IVC, we look at the SMA, we look at the hepatic vessels, we look at the renal vessels. So there's quite a bit that you can get through. And eventually intra-abdominal pathology. So that means you're looking for tumors, cysts, abscesses, all of that. But you'll notice what I've put here. It's with increasing experience levels. So in other words, it's no use learning about intra-abdominal pathology before you can look for free fluid in the abdomen. You have to walk before you can run in terms of ultrasound. So we really start here and we're slowly going to build up throughout all of these in our abdominal ultrasound lectures. And we're going to go quite far as well. Then what else does it give us? Quick bedside imaging of in the thorax, pneumothorax. Hemothorax and pneumothorax are close, but you first got to be able to see a pneumothorax, and then you've got to be able to see a hemothorax. Pulmonary congestion and pulmonary pathology. Now, pulmonary pathology is extremely exciting, a wonderful branch of emergency medicine and intensive care medicine. And let's just say there's a few lovely protocols that are out there that maybe once we start reaching towards the end of the year and you guys are very comfortable with pulmonary ultrasound, I'll even show you how we do those, all right? So, we're going to see things like PLAPS slides and blue points, and there's a whole lot of protocols, which right now, trust me, you don't want to know, but, at least let's start with the pneumothorax, okay? Pericardial effusion, that's the next thing that we need to know. So basic bedside echo, which is something we're going to get to as well. So if you're listening to this now, the first lecture on the 18th of February is going to be our first look at the subxiphoid view. So we're actually up to this point. We've already covered up till there, and we are now here, all right? This is thoracic, not thoracis, vascular assessment. So in other words, we're looking at the thoracic aorta. We can look at the subclavians. We can look at the internal jugulars. We can follow the IVC. There's a lot that we can look at inside here. When you have a patient with a thoracic aneurysm, there's various windows that we use. There's actually ways to, set up the thorax to actually do a central line placement of that, but that's another thing. And then we come to advanced bedside echo. So where we start looking at the heart in terms of the diagnosis that we are seeing, CCFs, ischemias, valvular disease, regurgitative disease, stenotic disease. So we can get to a lot, but again, this is the caveat, increasing experience levels. You can't just watch lectures, you can't just read books and go and say that I'll know how to go and diagnose, for example, a thoracic aortic aneurysm at the arch. The first time you put your ultrasound on there, you'll have no idea where to start and where to go. Okay. Then the last thing that we can use it for, I say the last thing, it's not really, but in this case, central line, peripheral vascular assessment. So looking at, for example, DVTs, looking at peripheral Dopplers, things like that. Central line insertion, peripheral line insertion, if you're lucky enough to have a high frequency probe, proper Doppler studies. Proper Doppler studies are quite intense. In our case, we would use it mainly in DVT. So this is really advanced once we get right to the bottom, but it just shows you the scope of things that we need to learn. And as we go through, you guys will get, every week, just a little advanced and a little bit more advanced. But I'll say it again, and I'll say it 100 times. The only way to actually figure out what's going on is to take that probe, put it on that patient. You can watch these lectures 1,000 times. Until you physically put the probe on the patient, you're never going to know what's happening. Okay. So what are the specific pros of ultrasound? It's not limited to a specific place. So if you want to do an ultrasound in an open field with a generator, you're perfectly welcome. You can do an ultrasound in ICU, you can do an ultrasound in the ward, you can do an ultrasound in FLIVIO, literally anywhere. It's useful in so many clinical situations, not just the emergency department. The renal departments use it so often. ICU uses it. Even in an outpatient setting, you can use it for so many things. Obs and gynae goes without saying, so it just shows you. The thing is, what it does is it gives us a quick, non-harmful way to look within certain body structures. It's not 100% diagnostic. The way I look at it is, ultrasound is kind of like looking at the body through safety shower glass. If you've ever walked into a bathroom, they have this misty glass. Looking through that, you can see there's somebody on the other side. You can make out that there is something that's going on. You can make out sometimes a lot of detail of that. But you can't see 100% sure what's going on. And that's the equivalent of what ultrasound is. As compared to CT and MRI, CT and MRI are when you actually open the door and look into the shower. The person screams and you close the door. No, I'm just kidding. But that's the difference. So CT, MRI give you much more information, but they are also far more invasive. Higher radiation levels, more contraindication. I mean, PET scan now. So ultrasound is something that every clinician can use. All right. It has a high specificity and sensitivity. So it's highly specific for what you may be looking for and very sensitive for what you're looking for if your operator is skilled enough. There's no radiation contraindication, so it can be used freely, absolutely freely in pregnancy. You don't have to worry. What are some of the cons? False negatives. So if there's too little free fluid in the abdomen, your patients only start becoming fast positive, EFAST positive. In other words, where we can say this is an acute abdomen with free fluid inside. Once they pass more than 150 mils of fluid, so less than that, we may miss it. Cannot detect free air in the abdomen. So you may have a peritonitic patient, EFAST comes back negative. This doesn't mean everything is fine. Do an upright chest X-ray or lateral decubitus. It will give you an example. It will give you information as well. In saying that, there's currently 2 studies going on that are trying to look at how the ultrasound can be used to see free air. If you look back at the pneumothorax, or if you look forward, sorry, in this case to the pneumothorax lecture, it has to do with how air is dissipated along ultrasounds, and there's a study to look at artifacts around the liver that could point to free air. So maybe by the time you guys are a bit more advanced, I'll be listening to a lecture by one of you describing how free air is seen under the diaphragm in the ultrasound, and I'm really looking forward to that day. It cannot tell you what fluid it is. So it can tell you that there's fluid. Now we're just talking about the abdomen. So if you see fluid around the liver, we don't know whether that's blood, urine, pus, bowel contents. We don't know what it is, but we know that there is fluid. It can give a false positive as well. So there may be fluid before trauma. For example, a patient with ascites, but now has suffered trauma. What's ascites? What may be blood? What may be urine? It's difficult to say. Patients with ventricular peritoneal shunts often have a lot of free fluid, but the difference there being, of course, you would get a history and you would be able to feel the shunt on either side, but it may not always be apparent. Peritoneal dialysis, ruptured minor ovarian cyst, there's quite a few things that can see. It's difficult to use in the setting of morbid obesity. So the more obese your patient is, the more adipose that ultrasound beam has to go through. And remember that ultrasound beam is being physically impeded by that adipose as well, right? The other thing is bowel gas, similar thing. So the more bowel gas, the more obese. These are not good patients to ultrasound. The good part with bowel gas is that if you just keep pressure, bowel gas tends to dissipate. If you keep pressure on fat, it doesn't dissipate. Otherwise, all of us would be absolutely thin. So unfortunately, it doesn't work. And the other thing is subcutaneous emphysema. So a patient has subcutaneous emphysema, that air that's now trapped in the tissues is creating a similar effect to what we would have seen in the pneumothorax lecture. It basically collects that ultrasound beam and dissipates it, so it gives you a very weird returning image, all right? Ultrasound is highly operator dependent. What that means is that an inexperienced provider is unlikely to find as many things as a experienced provider. So you have to understand your limitations as well. If you are in a new setting, let's say you work in a small hospital that does have an ultrasound machine, but you're not getting much instruction except from Dr. Mohammed, or you've read a book or something like that, and you scan like 1 or 2 patients a week, they're not really related to trauma, you're doing it on your own. By all means, do an ultrasound. And if you pick up something, mention it, but also mention your experience level during your transfer. I'll give you an example. I've picked up many ectopics in the A&E, very early ectopics, but I've let them know that this is my experience level. This is how many years I've been doing it. This is why I suspect, and I never have a problem. Can never substitute for a formal ultrasound. The reason why I say that, radiologists are trained in ultrasound very differently to how we are. So they will pick up things that we will not pick up. Not only that, the anatomical knowledge, the anatomical, their spatial anatomical knowledge is far beyond anything that we know. So please don't try and compete with them. You will lose. So the liver assessment. So where do you place the probe? The probe is placed in the right upper quadrant with the indicator facing towards the patient's head. You can also place it this way, it just creates a slightly different picture. So this is the normal view of what you would see. So this is your indicator up there. And remember, this is where the probe is. So the probe is essentially shining a light. So if you can imagine, this is not superior and inferior. This is actually medial and lateral. So this is the point where it is. It's shooting a beam medially to laterally, laterally to medially, sorry, laterally to medially. So you're seeing the liver in that slice, right? And as you move up and down, that's when you're getting more superior and inferior. This is towards the head, this is towards the abdomen. And a lot of people struggle with orientation, but as we go on, you would get it. So this is what a typical liver looks like. This is what the kidney looks like. Here we have the diaphragm, and here we have the lung, and here we have the spinal stripe as well. So that's normally what you are supposed to see. So now we're going to watch a little video on this. Okay.
Our next view is going to be the right upper quadrant, and this is a coronal view shooting from lateral to medial, with the indicator pointed towards the patient's head. Now, one concern is that the ultrasound beam is very thin, somewhere between 1 and 1.5 millimeters in thickness. So when we're imaging in the right upper quadrant, we're only getting a very small slice. We have to image the entire right upper quadrant, looking in the lower thoracic cage, looking in the right upper quadrant around the liver, around the kidney, and in the paracolic gutter. So while this is a very thin beam and a very thin section, there's a large area to view. Just like you would not look at a single CT scan, you would not look at a single image from the right upper quadrant. Instead, we're going to have to scan through the entire area to get an idea of what's going on in this three-dimensional structure based on our two-dimensional image. So we're going to start in the posterior area, and we're going to come anterior, and we're going to move throughout the interface and move anterior and posterior, scanning through the entire three-dimensional area to get our information. This is one of our cardinal views of the right upper quadrant, and you can see we're imaging from lateral, seeing the ribs, to medial, seeing the spine. We're looking at the liver, the kidney, the inner space between the liver and the kidney, the hepatorenal space, or Morrison's pouch as it's commonly known. We're going to identify the spine and the spinal stripe as a hard landmark. We want to also identify the diaphragm and the lung. And we want to look at fluid between the lung and the diaphragm and between the diaphragm and the liver. Now, unfortunately, there is a major artifact that you will see here. The diaphragm is a specular reflector. So what happens is sound beams leave the probe, impact the diaphragm. If there's aerated lung above the diaphragm, it reflects very well, and that sound beam is reflected into the liver. That sound beam hits liver tissue, and then that sound beam is then redirected to the diaphragm and reflected back to the probe. However, the ultrasound machine assumes sound travels in a straight line, so all of that sound is then plotted out in a straight line, and it assumes that liver is now above the diaphragm. This is called a mirroring artifact because the area above the diaphragm is mirrored from the area below due to the reflection. This is a normal artifact that will tell you there is aerated lung above the diaphragm. And you can see this because the spinal stripe stops at the diaphragm, and as we all know, the spine does continue past the diaphragm, but what we see above the diaphragm is the absence of the spinal stripe and the presence of what appears to be liver. And if you look closely, the liver matches on both sides of the diaphragm with hepatic vessels noted on both sides. You can see the spinal stripe stops there right at the diaphragm, and we see this area mirroring there showing what looks like liver above the diaphragm. This tells me that there is aerated lung opposed to the diaphragm or normal interface. Here's another example of the right upper quadrant, and this is what we're looking for in the upper part of the right upper quadrant. Now, the entire interface in the right upper quadrant may not be able to be obtained in a single video clip or single scan through, and you may need several video clips to capture all the parts. What we're looking for is the liver, the kidney, the hepatorenal space or Morrison's pouch, and here we can see the upper portion of it, but not necessarily the inferior portion. We're looking for the spinal stripe or this bright corrugated hyperechoic line that denotes the spinal bodies. It ends at the diaphragm, which we can see here, and beyond that we see mirroring, telling me that there's no fluid above the diaphragm. We're going to image a little more inferior here, and we're also looking for the liver, the kidney, Morrison's pouch, and here we're looking at the mid and inferior portion of Morrison's pouch that we cannot see because of the size of the liver in order to get a clearer view of the diaphragm. We will see the spinal stripe here as our hard landmark. We do see part of the diaphragm, but we don't see above it as well. And here we can see as we're scanning through, we're looking more at Morrison's pouch, seeing that hepatorenal interface a little more clearly. And you can see as we slide more inferior, we're getting a better view of that distal portion. Here we can see a lot more of that area, and we're also evaluating the inferior pole of the kidney, which is the paracolic gutter. When you see mention about imaging the paracolic gutter in the FAST exam, what they're really talking about as a hard landmark is the inferior pole of the kidney. You will also see that we've evaluated the entire hepatorenal space as we see the liver tip. Now this may be anterior where you're seeing some bile gas pattern, and normally we try to avoid the bile gas because that tells us we're intraperitoneal versus the hepatorenal space with the kidney being retroperitoneal. What we want to identify here is the liver, and there's going to probably be some loops of bowel, and what we're looking for as we slide inferior and anterior is that inferior tip of the liver. And the reason being is fluid will begin to collect at the paracolic gutter, at the inferior pole of the kidney, or the inferior tip of the liver before that fluid begins to track into the hepatorenal or Morrison's pouch. You will see the inferior tip of the liver, which is the beginning of the hepatorenal space, and the paracolic gutter. Small amounts of fluid will collect here before it begins to dissect or track through Morrison's pouch. So if the patient is very early in their course or has been transported very quickly or has very small amounts of fluid, you can miss it if you do not evaluate the inferior pole of the kidney and the inferior tip of the liver. You can see here an example of free fluid. You see anechoic areas with sharp corners in between the liver and the kidney. However, you see a lot more fluid accumulating in the paracolic gutter near the inferior pole of the kidney and the inferior tip of the liver, rather than superior between the liver and the kidney. So you can see that a lot more fluid accumulates in this area before it tracks into Morrison's. So if you're not evaluating the entire right upper quadrant, you may miss small amounts of fluid. Here's an example of a large amount of free fluid separating the kidney and the liver in Morrison's pouch or the hepatorenal space. Here's another example with fluid in Morrison's pouch, and you can see it's anechoic with sharp angles. Because remember, anatomic structures are rounded, and when you have two rounded structures next to each other, that space will then have sharp points. Here's a view where we no longer see mirroring, and what we're seeing is fluid above the diaphragm. You can see the spinal stripe extends. The spinal stripe does not end at the diaphragm, highlighted by this arrow. It instead extends past it. And what we're seeing are the findings to diagnose a pleural effusion. We see extension of the spinal stripe. We see an absence of mirroring, and we see anechoic fluid above the diaphragm. With those three findings, we do have pleural fluid. And if it is a traumatically injured patient, we are concerned about a hemothorax.
Okay, guys, so that was quite a lovely video that I had found some time ago. And it's something that you can watch over and over again just to get the idea of liver assessment. Okay. So what we're going to do now is we're going to have a look and say, how do we know it's a positive study? So when I did it with the guys, we went through each one, but I'll just go through it a bit more easily here. So when we put our probe here and looked at the tip, see that's the tip of the liver, you can see the kidney, you can see a large amount of free fluid there. Now, as you know, they described it as anechoic. Anechoic means produces no echo. So in other words, it's absolutely dark. Then you get hypoechoic, which means that it's reflecting, but not as much. So for example, a dull area like that might be hypoechoic, whereas a bright area like that would be called hyperechoic, and this is anechoic. All right. So there we can see a large amount of free fluid. We come across to the second one. Here you can see the kidney, the liver, the soft tissue at the top, and you can see large amounts of free fluid again. So in the presence of trauma, this is quite worrying, and it does mean that we have to get this patient to theater. Let's look at another one. So this is a one with small amounts of free fluid. Now, if you are confused as to whether this is free fluid or something else, look at the angle. If you follow the angle just there, you can see it forms a sharp angle at both edges. Your patient will be peritonitic in this case, but this is a positive study. But you can see it's such a small amount that if you don't scan through the entire liver, you may not get everything. Okay. This one here, we are actually seeing the liver, the diaphragm, the spinal stripe that continues. This is a pleural effusion. Let's say it's trauma, hemothorax. And this little wavy thing that you see over there is actually the lung. All right. So I hope I've given you guys some idea of what you need to look at. So this is just one more thing to look at. So normal versus a cirrhotic liver. Normal liver, nice and puffed out, very easily notified granules. Whereas here on a liver, cirrhotic liver, very often the shape is either it's decreased. It very rarely is hepatomegaly with cirrhosis. Remember that, and you have very poor vasculature. All right. So just out of interest sake, I just wanted to show you guys that. And this is just a tear, a liver laceration. So this is actually seen, you can see that the right lobe of the liver, and we can see a tear that goes through, but you can see how tiny it is, and it's very difficult to make out. But just that you know, eventually, as you become more and more experienced, you will be able to find this. The one little clue is actually there's a bit of fluid, which is blood above the capsule. So those are little things that you can look for. So I hope you guys enjoyed that. And if there are questions based on this, even though you weren't part of the first lecture, by all means, please ask me and we will try and answer as best as possible. But please enjoy it. And I hope you guys learn from it as well. Okay. All right. Bye.